Hello again. This presentation is going to discuss the fourth stage of labor as the woman's body goes through the process of returning back to its pre-pregnant state. We're going to talk about what to expect as well as problems to be on the lookout for. The postpartum period starts from the delivery of the placenta and goes to about 6 weeks out. Back in the day, women would stay in the hospital for a week or two after delivery to ensure that everything went okay and to show mom how to take care of herself and the baby before she goes home. Nowadays, ladies stay in the hospital for roughly 48 hours if it's an uncomplicated vaginal delivery. Since the postpartum period lasts up to 6 weeks, problems can develop later on once she gets home. So we need to be sure that we cover some very specific things with her, and we really don't have that much time to do it. In that 48-hour span, we have to provide the care she needs, hands-on patient care in the hospital, and do a lot of teaching on how to take care of herself and her baby. So if you're providing optimal postpartum care to your patients, you're very busy, either doing patient care or teaching. 48 hours is not a lot of time. The postpartum period is also called the puerperium, and as I said, it starts from the delivery of the placenta and lasts for about 6 weeks. Most facilities have moved from having a postpartum unit and a newborn nursery to having a mother-baby unit where moms and babies share a room and one nurse takes care of both of them. This setup provides more opportunities for moms and babies to interact and bond. It also allows mom more time to learn how to care for her baby with the nurse there to help. Rooming in has also been shown to increase breastfeeding success. Moms and babies are able to breastfeed on demand, and mom is given the opportunity to learn her baby's early feeding cues. These are the behaviors that the baby will demonstrate that will let mom know that he or she is hungry. Crying is a late sign of hunger, and it's a lot harder to get the baby latched on once they reach that point. Vital signs are usually the first part of any postpartum assessment. Determining the value of the vital signs will cue you in on what other assessments you might need to do. For example, if the temp is elevated, you might want to determine if the mom is dehydrated or developing an infection. A slight elevation of the temperature, which is less than 100.4, especially if it's in the first 24 hours, is not usually anything to be concerned about. If the blood pressure or pulse is elevated, you might want to assess her pain. Most moms have a period of bradycardia right after delivery related to increased maternal blood volume, or tachycardia might be due to dehydration or increased blood loss, so you have to investigate. Respirations are usually normal, but they need to be closely monitored, especially if you're giving narcotics for pain relief. Moms may experience orthostatic hypotension related to inadequate fluid intake or excessive blood loss. Elevated blood pressure may indicate the presence of worsening of preeclampsia. And risk of preeclampsia is still present after delivery, but will gradually decrease as the mom reaches the end of the postpartum period. Excessive blood loss is a major concern in the postpartum period. Postpartum hemorrhage is the leading cause of maternal death in this country. There are 3 postpartum physiologic changes that protect mom from excessive blood loss. The first is elimination of the intrauterine placental circulation. This basically reduces the size of the maternal vascular bed by about 10 to 15%. Basically, what it means is less blood is going to the uterus because without the baby in the placenta, the uterus doesn't need much. Second is the loss of the placental endocrine function. The placenta generates hormones that cause the mom to vasodilate so her body can accommodate the increased blood volume she gets when she's pregnant. Without the placenta, the stimulus for the vasodilation is gone. So those vessels contract, which raises her blood pressure. Third is the mobilization of the extravascular fluid stored during pregnancy. Pregnant women are very puffy. Their body hangs on to fluid which gets stored in the tissues. Once the pregnancy is over, that fluid gets shoved back into the circulatory system. This increases the blood volume. Therefore, most women usually don't have a problem with hypovolemia as long as they sustain a normal blood loss. Normal blood loss for a vaginal delivery is less than 500 mLs, and blood loss for a C-section is less than 1,000. As far as the blood components go, the hemoglobin and the hematocrit levels are increased by about day 7 due to loss of plasma. On the postpartum unit, you kind of have to sort it all out. Is the hemoglobin and hematocrit up due to dehydration, or is it a normal change? Or maybe not as much blood loss as we thought, or is it down due to overhydration or blood loss? As far as the white blood cell count, during pregnancy it's about 12,000. The first 10 to 12 days in the postpartum period, you might see values of 20,000 to 25,000. This is a normal finding, so it can be difficult to pick up if mom's developing an infection. And as far as coagulation factors, these increase during pregnancy and remain so in the immediate postpartum period. Patients have an increased risk of thromboembolism up to 2 weeks postpartum. There is an increased risk, and even more of an increased risk if she has a C-section because of immobility. So be sure and check for any unilateral pain or swelling in one of the lower extremities. BUBBLE is an acronym that we use to address all the aspects of a good postpartum assessment. There are additional pieces to do a complete assessment that you perform on a postpartum woman, but these are the items that are specifically affected by either pregnancy or birth. BUBBLE stands for breast, uterus, bladder, bowel, lochia, and episiotomy or laceration. The EE at the end stands for extremities or emotional status. The acronym used to be BUBBLE-HE with the H standing for Hohenstein, which we used to check to determine if a patient had a DVT or a deep vein thrombosis. And we also had an E for edema, which is another sign of DVT. We have changed the H for Homans and the E for edema to E for extremity, and we now look for unilateral pain, swelling, or redness in one leg or the other. And we added the E for emotional status. I wanted to explain this to you because you might still hear the term Hohenstein, but current literature no longer supports doing this. And emotional status is very important. Postpartum depression is really important and is the most common ailment suffered by pregnant women. By postpartum women. Okay, so now let's go into detail, starting with breasts. Many women will initiate breastfeeding while they're there in the hospital with you. So for the breastfeeding woman, initially breasts are soft and secrete a yellowish fluid called colostrum. Colostrum is just chock full of antibodies, so it gives the baby a good boost to their immune system, and it has a laxative type effect, so it helps the baby pass that first meconium stool, which is kind of sticky and gross. Breasts of moms who are breastfeeding as well as those who aren't are usually tender, and when they fill, they become warm and firm, and this usually lasts for the first 48 hours. Mature milk comes in by about day 3 to 5. For moms that are breastfeeding, be sure to assess for nipple inversion, flatness, or eversion, cracks or blisters or reddening of the skin to see if the baby's latched on properly. If mom's nipples are really sore, she's going to stop breastfeeding, so we want to avoid that. And also have her avoid any soap on her nipples when she's showering. And check for a good latch. Always ask mom if you can watch her get the baby latched on, and watch the baby nurse at least one time so you can make sure everything's going okay. For moms who aren't breastfeeding, their milk is still going to come in, and engorgement usually occurs on day about 3 or 4. Breasts become hard and tender and warm to touch. Encourage moms to wear a tight bra. She can use ice or cabbage leaves, a mild analgesic. Tell her not to express any milk, because the more milk she removes from her breast by either the baby nursing or if she's expressing or whatever, the more milk her body's going to make. As long as you keep pulling it out, her body's going to keep making it. So tell her when she takes a shower, also face away from the water, because the hot water on her breast can actually stimulate milk production. And have her watch for signs of mastitis, which are warmth, fever, and pain, and redness. Seems just easier to breastfeed, doesn't it? Now let's look at the U for uterus. The term used to describe the uterus returning to its pre-pregnant state is called involution. The process of autolysis destroys excessive hypertrophied tissue from the pregnancy hormone. Most of the endometrium sloughs off in the lochi and is replaced by a new endometrial layer in about 3 weeks, except for the tissue at the placental site. This process at the placental site will take up to 6 weeks. Why is this important for you to know? Well, until that endometrial layer is completely back to normal, the woman is still at risk for bleeding and possible hemorrhage. So the risk of postpartum hemorrhage is greatest in the first 24 hours and will gradually decrease with each passing day. But the woman is not completely out of the woods until about 6 weeks postpartum. So you always want to teach her what to look for as far as increased bleeding, and especially when she goes home, when to call and when to come back in. And fundal height should gradually decrease, and we want to monitor that at least while she's there in the hospital. At the end of the third stage of labor, the fundus is approximately 2 centimeters below the umbilicus, but at 12 hours postpartum, it's about 1 centimeter above, and that's normal. But by about 24 hours postpartum, it's slightly below the umbilicus again, and descends 1 to 2 centimeters every 24 hours until it's all the way back down behind the pubic bone again. A fundus that is higher than expected, or deviated from the midline, or boggy, needs to be addressed immediately, as this can be a sign of impending increased bleeding. And once again, that's a bad thing. And we're going to get into that in just a minute. Fundal massage is an intervention that nurses can do to address a boggy uterus. We do it by supporting the lower uterine segment and massaging the fundus gently but firmly. Don't overdo it. This is something that you can do on the postpartum unit or on the labor and delivery unit right after delivery. And hopefully when you're in the hospital, you'll get a chance to do this. The uterus should firm up pretty quickly, which helps to prevent excess bleeding. So what do you do if the fundal massage doesn't work to firm up the uterus? You stay with the mom, you continue to try to massage, and you call for help. You do not leave the mom. You call for help and have someone else get you the things that you need, or call the doctor or whatever. You stay at the patient's bedside. After pains are uterine contractions produced by oxytocin, and that oxytocin may be endogenous, which means it's released after delivery or with breastfeeding, or exogenous, which means we give it to her through an IV. Periodic relaxation and contraction of the uterine muscles is normal, and that's what causes the after pains. They can be mild, or they can be very uncomfortable. Moms who've had multiple babies or have a large baby or are breastfeeding tend to be more uncomfortable because their uterus is either contracting more, as with the breastfeeding, or contracting harder and longer to shrink back down to the normal size it was if you have a big baby or multiple babies. Pharmacologic and non-pharmacologic interventions can help to alleviate them. The cervix after birth is very soft and floppy, and so nothing should enter the vagina until the cervix returns to its normal consistency, which won't be for a few weeks. After a mom has had her first baby, the cervix doesn't look like it did prior to that delivery. The external os, or the opening, prior to that first delivery looks more like a dimple, but after that it looks more like a slit, and it'll stay that way for the rest of her pregnancies. It'll return to that normal slit shape. Now let's talk about the bladder. The pregnant woman, as I said, is very puffy. All those hormones that were excreted during pregnancy are starting to dwindle, all those hormones that were helping her to retain fluid, and now she's going to pee like a Russian racehorse as her body gets rid of all that extra fluid. And this process actually has a name. It's called postpartum diuresis, and it occurs about 12 hours after delivery and continues for about 2 to 3 days. All that extra fluid is going to return to her circulatory system and end up in her bladder. So we, as nurses, need to make sure it's coming out. After vaginal delivery, there can be trauma that was sustained to the urethra or the bladder. This may inadvertently cause swelling, which can make it hard for her to pee. In addition, she may not feel like she has to pee due to desensitization caused by an epidural or spinal, and she might have slightly increased bladder capacity as everything's kind of relaxed during pregnancy, but she still needs to pee. An overdistended bladder can cause the uterus to not be able to contract down as it should, which can cause her bleeding to increase. So we need to make sure that our postpartum moms are peeing, and if they aren't, we need to find out why and fix it. So how do we assess the bladder? Well, we can palpate it for bladder fullness, but we can also look at things like vaginal bleeding. A distended bladder will cause increased vaginal bleeding or increased lochia, so we can pick up on that. In addition, the uterine fundus will be displaced upwards into the side. This is a clue that the bladder is full. Have your patient void and then massage the uterus to see if it becomes less boggy. In addition, the mom that has an increased risk for moms have an increased risk of urinary tract infection if their bladder is over-distended. Bladder tone usually returns to normal at about 5 days postpartum. Birth-induced trauma or pelvic pain from vaginal lacerations or repair or an episiotomy can cause an anxiety, and the mom might not want to pee because she's afraid it's going to burn. Things that you can do is give her a peri bottle and have her run some warm water or pour some warm water over her perineum while she's peeing. This will help to dilute the urine and it won't burn so much when it comes in contact with that lacerated tissue. You might also actually need to catheterize her if she cannot empty her bladder. Moms need to pee at least 150 milliliters each time she uses the bathroom. The third and last B is for bowel. The bowel is very sluggish following birth, and that's related to the decreased muscle tone from the pregnancy hormones, or it could be the anesthesia from a C-section. But either way, it may take mom 2 to 3 days to have a bowel movement. In addition, women that have lacerations or an episiotomy or stitches or hemorrhoids or anything like that might actually be holding it because they're afraid of the pain. They're afraid something's going to happen if they have a bowel movement. So things that you can do to help mom is early ambulation. The more she moves around, the more likely she is to have one. Increase fluids and fiber. And the provider may also prescribe a stool softener like Colace for the first couple of days. The L is for lochia. We have to assess mom's bleeding. Postpartum hemorrhage is the leading cause of maternal death. We've already said that. Lochia is divided into 3 groups. There's lochia rubra. This is what you see first. It occurs the first 2 to 3 days after delivery, and it's like a very heavy menstrual period. It's heavier initially and then gradually decreases in amount. Vaginal discharge is composed of blood, decidua, trophoblastic debris, and is initially bright red, changing to a reddish brown or a dark red. Next comes lochia serosa, which starts at about day 3 or 4 in the postpartum period and is pink or brown in color and contains old blood, leukocytes, serum, and tissue. And it lasts from about day 3 to 4 to about day 10 after delivery. Then comes lochia alba. It's yellow or whitish in color and contains leukocytes, decidua, epithelial cells, mucus, serum, and bacteria, and can last up to 6 weeks. Lochia is usually less with a C-section. It may increase with ambulation or exertion or breastfeeding, because that actually contracts the uterus and anything that's in there is going to get squished out. If the client has been lying down for some time and then gets up out of bed, she might have a gush. That's just from the blood that's had a chance to pool as she was laying there. It usually will be dark red, and it might have some small clots, because blood that pools anywhere clots. If lochia rubra continues after day 3, it may indicate that there is some retained placental fragments, and the provider needs to be called so he can address this, he or she. Lochia flows much like a period. It may increase with exertion, but it should gradually decrease. If lochia increases, be sure to assess the fundus. If the fundus is boggy, then massage it. Initially, fundal massage may increase lochia as the pooled blood is expressed out of the uterus. The same thing happens with breastfeeding. As I said, pooled blood anywhere in the body will clot, so you might see some small clots, but clots the size of golf balls or larger should be reported. If you see increased bleeding and the fundus is firm, call the provider immediately, as this could indicate a cervical or a vaginal laceration that needs to be sutured closed. Lochia has a musty odor, but it shouldn't smell bad or be offensive in any way, shape, or form. If it does, you need to report this as well. Blood loss is usually documented as scant, light, moderate, or heavy, and there's pictures of what this looks like on page 662 in your book, and it shows kind of what we're talking about. We have touched on most of this, but it bears repeating. Uterine atony, or a boggy uterus, is the most frequent cause of excessive bleeding. Basically, it's failure of the uterine muscle to fully contract, and it's important to maintain good uterine tone and prevent bladder distension to decrease the chance of excessive bleeding. When uterine tone is decreased, the uterus fills with blood and clots form. Basically, the placental site bleeds. Excessive bleeding can also be caused by vaginal or vulval hematomas, which is basically bleeding underneath the skin like a bruise. You won't see increased lochia, but as blood is still leaving the circulatory system, which is where it needs to be, the patient may still show signs of shock if the hematoma is large enough or is significant enough. And as I've already said, excessive bleeding can be caused by vaginal or cervical lacerations or retained placental fragments. Lochia can be measured by visually estimating the amount and classifying it as scant, moderate, or heavy, etc. But it can also be weighed in an actual amount of blood loss given in milliliters. You can weigh the peri pad or the blue chucks or whatever the blood is on, and then subtract the dry weight, and 1 gram equals 1 milliliter of blood. I would highly recommend weighing these things, especially if you're concerned about the bleeding, to get an accurate amount. Now we're going to move to our first E. We need to assess the episiotomy or the laceration. We use the acronym RETA when assessing for infections of any laceration or wound. RETA stands for redness, edema, ecchymosis, discharge, and approximation. Episiotomies or lacerations usually heal within 2 to 3 weeks. So you need to actually look at it and make sure that you don't see any of these signs. And while you're down there checking the perineum, look for signs of a hematoma, which might be discoloration and swelling of the tissue. If a hematoma is present, the mom will usually complain of severe pain. Some moms say it's more painful than labor. If this is the case, you always want to suspect a hematoma. Teach moms good hygiene also. It is very important that the perineal area be kept clean. She can perform sitz baths if she likes. This helps to clean the area without a whole lot of wiping. She must also change her pad every time she voids, which if she's peeing like she should, like the Russian racehorse we talked about, this should be pretty frequently. The sitz bath can also help to soothe hemorrhoids, which usually shrink by about 6 weeks. She can also use Tex pads, which is basically witch hazel, but she wants to watch for thrombosed hemorrhoids. Those need to be addressed. Lack of estrogen affects the rugae and the mucosa of the vagina, which cause vaginal dryness. And breastfeeding moms may experience vaginal dryness anyway because of decreased estrogen associated with breastfeeding. So once she's been cleared to have sex, she might need to use a water-soluble lubricant, and you can go over that with her. The second E stands for extremities. As we've said, pregnant women clot fast, which is good, or else they would all bleed to death after delivery. But they need to clot where they need to clot. We know that blood that pools anywhere clots. Therefore, pregnant women can get clots other places, which we don't want them to. We always want to assess for thrombus formation, especially in the lower extremities, and we look for redness, warmth, pain, diminished peripheral pulse below the site of the thrombus, and unilateral swelling where one leg might be bigger around than the other. Early ambulation helps to prevent thrombus formation, which is why C-section patients are at greater risk. They usually spend the first several hours after delivery confined to bed. If a thrombus is detected, the patient needs to be placed on strict bed rest so activity doesn't dislodge the thrombus. They need to elevate that limb, and we need to contact the doctor. Don't massage, even if the limb is sore, as this might dislodge the thrombus and it might travel somewhere we don't want it to. Once again, early ambulation is very important. Ambulation helps decrease the risk of thromboembolism and also increases, the strength of her recovery. Moms are going to be sore, and she might not want to get up, but it's our job as nurses to explain to her why it's important to ambulate and to help her those first couple of times. Be with mom when she's getting out of bed for the first time. Even if she just gets out, to go to the bathroom, stay in the room until she is done, and you can help her back to bed. She may feel weak, faint, lightheaded, or dizzy, so that's why you always want to be close by, especially the first time. If bed rest is indicated, like a mom who's had a C-section or a mom who's on magnesium sulfate, try to encourage movement of the legs while in bed. Things like circling her ankles around or flexing or extending her feet or legs can help with the circulation in her lower extremities. As I said, edema has kind of been replaced, although, almost all pregnant women are going to be, postpartum women are going to be a little puffy. We already said that, especially in their legs, because that's usually the lowest part of their body. But if you happen to see edema in her face, then that's something that needs to be addressed. It might be a sign of preeclampsia, which we've already covered, but as I said, it can still happen in the postpartum period. The last E is for emotional status. We definitely need to assess this, especially if the mom had a difficult delivery or her delivery was significantly different from what she planned. Like maybe she wanted to have a natural birth but ended up with an emergency C-section. Or maybe she's now on bed rest and her baby's in the NICU, so she can't get up and go see him or her. So we need to check on these women and see how they're doing emotionally. Well, we need to really check on all our moms. You never know how someone is going to react to something. She might have concerns about her body. She may not think she looks the same. She might be like I was when I had my first baby and I had brought my normal size 6 jeans to the hospital with me that I was going to slide right back on as soon as that kid came out. Never occurred to me that they wouldn't fit. She might have concerns about her self-concept or body image. She might think that her partner doesn't find her attractive anymore. She might fear pain when intercourse is resumed later on. The majority of women, about 85%, will experience some sort of postpartum blues or baby blues. Symptoms usually include weeping, insomnia, irritability, anxiety, forgetfulness, mood swings, negative feelings. Basically, she's hormonal. She's also sleep deprived because she's feeding a newborn baby, which only exacerbates these feelings. Usually appears within 1 week of delivery, and it's usually gone by postpartum day 10. Attachment behaviors might be affected, but we'll discuss that later. Postpartum depression is more significant than baby blues. The mom might be withdrawn and might not want to talk. Most moms love to share their delivery story, good or bad. You can't shut them up. But if a mom is unwilling to talk about her experience, that might be a sign. Or maybe she's having self-esteem problems. She feels ugly, or she feels like she's not meeting the mark as a mother. Or she's a first-time mom. All of these things put her at increased risk. Some other risk factors of postpartum depression are history of a major clinical depression prior to pregnancy, during pregnancy, or she has a history of postpartum depression from a previous baby. Also, lack of an adequate support system with an attentive partner or the mother's parents if she's young. And of course, complications of delivery that adversely affect her or her baby. The baby ends up in the NICU, mom's on bed rest, or, the baby dies, Lord forbid, can all increase the risk of postpartum depression. Possible signs of postpartum depression include expressing disappointment with the baby's gender, or seeing the baby as messy or ugly, or the baby reminds her of someone she doesn't like the father who she might not be with anymore. Other signs are not interacting with the baby or caring for the baby. These are things that you might see in the hospital, but you always have to, as far as not interacting, you have to take that with a grain of salt and always consider culture first. In some cultures, the grandparents are the primary caregivers for the baby until the mom fully recovers, and that's normal for them. So we finished up the bubbly, and here are some odds and ends that we didn't get a chance to cover, but are still important. The abdominal muscles take about 6 weeks to return to the non-pregnant state. Moms can have a separation of the abdominal wall muscles known as diastasis recti abdominis, and there's a picture on page 653 in your textbook. This is very seldom anything to worry about and hardly ever requires surgical repair. It will shrink and become less apparent with time, so reassure mom of this. Problems like sciatica are relieved, as the pressure gets off of those nerves. You always want to be careful when assessing for headache complaints in the postpartum period. This might be due to either postpartum hypertension, stress, or maybe a wet tap from an attempted epidural placement. Delivery brings relief from most joint pains and relief from pubic bone pain from the relaxin that's been circulating throughout all of her pregnancy, and joints usually stabilize by about 6 to 8 weeks. Stretch marks on her breasts, abdomen, hips, thighs will fade, but usually don't completely disappear. But they might be bright red or pink initially, and they'll fade to kind of a silvery. Cloasma, or the mask of pregnancy, usually disappears. Hyperpigmentation of the areola and the linea nigra usually disappears, but can remain in some women. Some moms experience excessive hair loss, but this is temporary, and her fingernails return to their pre-pregnant state. So all of that luxurious hair and smooth, strong nails go away. Sorry, moms. Other things to think about in the postpartum period is infant security. The staff usually has and must use staff ID badges. They also instruct the parents to look for these badges and not to release their baby to anyone who doesn't have one. That includes us and students, so just be aware of that. The hospital will also have an alarm system which will automatically lock all the doors and elevators if activated. We refer to this as a code pink. If you hear this, the staff is usually running to any available exit while others are starting to check the rooms for any suspicious person or baby. Babies don't have much of an immune system, which is why breastfeeding is so important. But something else is good hand washing, because they don't have any way to fight off any sort of germs. Pain is also a concern. Our goal is always for the patient to be pain-free, but probably a more realistic expectation is just to reduce it to a tolerable level. I have yet to meet the postpartum mom who has no pain at all. And we can do that much the same way we did in labor, through non-pharmacologic and pharmacologic interventions. The non-pharmacologic are things like heating pad, distraction, deep breathing, imagery, relaxation, all the things we talked about with labor. And of course, the best distraction is a cute little baby that she has with her now. So interaction with her baby is always nice to see and is usually helpful. Pharmacologic interventions include oral pain meds or IM or IV narcotics, a Toradol or a patient-controlled analgesic pump or PCA, or maybe an epidural with an intrathecal if she had a C-section. Moms may express concern about pain meds and breastfeeding. Most meds that a new mom would be given are perfectly safe to give if she's breastfeeding, but if she's still concerned, you can tell her to take them immediately before nursing so the drugs won't have time to get into her milk, or immediately after. This allows the greatest amount of time between feedings. But always remember to assess within an hour of receiving the pain meds to make sure that they've worked. Fatigue is also common due to pain, feeding demands of the infant, or just being in a strange place. Moms don't rest well. They may be anxious or depressed. We can do things like back rubs or massage or other comfort measures to decrease her anxiety, and sometimes a little bit of a sleeping medication is helpful. Other pharmacologic interventions that have nothing to do with pain, but are given in this same time frame, are rubella and Rogan. Moms who are not rubella immune will be offered this vaccination after baby delivers, because if she contracts rubella with the next pregnancy, it's got horrible birth defects associated. But you also want to avoid giving this vaccination if mom or a member of her household is immunocompromised, because this vaccine can shed the virus through urine and body fluids. Assess to see if mom is allergic to duck eggs. That's also something that we want to be sure that we don't give her rubella if she is. It's important for moms not to become pregnant for at least 2 to 3 months after she gets the vaccine, because once again of the teratogenic effects of rubella. Moms who are Rh negative may give birth to a baby who's Rh positive and would need an injection of what's called Rogan within 72 hours of delivery. The Rh immune globulin promotes lysis of fetal Rh positive cells so the mom doesn't form antibodies against them. And that's to protect the next baby that she has. If the next baby that she has is also Rh positive, has an Rh positive blood type, mom will have antibodies in her system which will attack that baby. So we always want to give Rogan after delivery to help her from developing these antibodies. If the mom receives Rogan and rubella during the same postpartum hospital stay, she should have an antibody titer drawn in 3 months to see if she is rubella immune or not, because Rogan suppresses the immune response and antibody formation of the rubella vaccination. Discharge from the hospital of an uncomplicated vaginal delivery is usually about 48 hours, but can be up to 96 hours for a C-section. Some medical problems don't show up, as I said, until after this period, or maybe even longer. So there's a concern about maternal-infant interaction, health care, breastfeeding, etc. We're also concerned about the short amount of time for teaching. Ideally, teaching should begin on admission to the hospital. So if she's admitted, if she's still relatively comfortable at the beginning of labor, you might want to go over a few things about what she's going to expect. If you try to put it all off until an hour or two before she's due to leave the hospital, she's not going to retain any of it, and it's just going to be a waste of time. There also might be an option for follow-up visits, or at least a follow-up phone call at about day 3 to 4 if mom is discharged on day 2. Criteria for discharge teaching is listed on page 686. Discharge teaching must always include signs of complications that the family needs to watch out for. Increased bleeding or passing of large clots, or if the loci is foul smelling, or there's a fever of over 100.4, all significant signs, including signs of a depression, that needs to be reported immediately. Discharge teaching should also include sexual activity and contraception. The mom and dad more than likely won't bring this up to you. So if you don't bring it up, then they're going to leave the hospital without a solid information, which can lead to problems. So they need to know that sex can be resumed when the bleeding is stopped, but almost all providers say about 4 to 6 weeks. Before 2 weeks, though, can definitely put her at risk for developing an infection because her cervix is still kind of open and floppy, so they need to know that. Ovulation in the non-lactating woman can return as early as 27 days postpartum, and she will ovulate before her first period. That's how it works. So she could get pregnant before her period ever starts. Most women who are not breastfeeding resume having regular cycles by about 3 months. Women who are breastfeeding may delay ovulation for up to 6 months if they're exclusively breastfeeding. So make sure that they know that. The first period after delivery is usually heavier than normal, and so you can tell moms if this is normal, they don't have to worry about it. And as far as exercise, resume activity gradually, and abdominal exercises should not start until about 4 weeks because those abdominal muscles are open, like we talked about. But Kegel exercises can start with the first void. Observe cultural and dietary needs as it pertains to nutrition. We want moms to be able to eat what she wants to eat, but she needs to eat well because nutrition impacts breastfeeding, weight loss, wound healing, constipation, and a myriad of other things. So it's important to cover this. We also need to make sure she understands how to take her prescribed medication. Well, she'll probably be pain meds, prenatal vitamins, iron, stool softeners, or laxatives. We need to make sure she knows when to follow up. For a vaginal delivery, she follows up in about 6 weeks. For a C-section, she might be seen in 2 weeks and then again at 6 weeks. The infants are usually seen by 2 weeks at the latest if they're not seen sooner for a weight check. Talk to her about follow-up options that are potentially available to her, like maybe home visits or telephone follow-up, or something called a warm line, or some call it a helpline, or a nurse advice line. There's also support groups. These are very beneficial, especially for moms who are breastfeeding. The La Leche League is a great one. Most moms and babies thankfully deliver without any problems and are discharged home as healthy, happy couplets. But there are some complications in the postpartum period that can happen, so we're going to talk about these for a minute. Let's start with postpartum hemorrhage. As I said, postpartum hemorrhage is the leading cause of maternal death in this country, and it's defined as a loss of 500 milliliters for a vaginal delivery and a loss for 1,000 milliliters for a C-section, or a drop of 10% or more in the mom's hematocrit from admission. And postpartum hemorrhage is divided into either early or late. Early hemorrhage is within the first 24 hours, and this is when the mom is at greatest risk for hemorrhaging. But there is something called late, which is from 24 hours up to 6 weeks. See Table 30-1 on page 718 for some signs. Due to increased blood volume, mom might not show typical signs of hemorrhage, like decreased blood pressure, increased pulse, decreased urine output, until much later, much further down the road, until maybe as much as 1,800 to 2,100 mLs of blood are lost, shortly before she becomes hemodynamically unstable. So we want to make sure we catch it early. Some causative factors are going to be talked about next. Uterine atony is the #1 cause of hemorrhage, and it's associated with high parity, multi-fetal pregnancy, prolonged labor, lots of oxytocin, retained placenta, placenta accreta, placenta previa, myriad of other things. Treatment is usually fundal massage, making sure the bladder is not over-distended, and giving meds like Pitocin or Methadone or Hemabate. There's a chart on page 714 with more details about these meds. We also want to draw labs, like a hemoglobin and hematocrit or an H&H. We also want to check the platelets, a coagulation panel to see pretty much the extent of the damage. We also want to replace that volume with fluids, or better yet, blood. Mom may need surgery if other options do not control her bleeding. Worst case scenario, we might have to actually remove her uterus if we can't get it to stop bleeding. Next is lacerations of the genital tract. And these symptoms include bleeding with a firm fundus, and causes are operative birth, precipitous delivery, size or position of the fetus, or just being a first-time mom. Hematomas can also develop, as we've already said, and they usually develop in the vulvar, vaginal, or retroperitoneal area. A mom can lose a lot of blood into her pelvis, so if we suspect a hematoma, we want to notify the doctor immediately. Signs and symptoms, once again, are pain. This is the most common sign, and it's severe pain, much worse than expected, as well as feelings of pressure or fullness in the vagina. You might actually see symptoms of shock if the hematoma is severe enough, but with minimal vaginal bleeding. Nothing's coming out, but she's still showing signs that she's losing blood. Treatment includes surgical repair of the laceration or evacuation of the hematoma, along with ligation of those vessels that were feeding it, and then continued observation for further complications. Might also have cold packs. That might help. We also need to give mom some additional fluid or maybe some blood replacement. We also want to draw labs like an H&H, platelets, coag panels are a good start. We need to make sure we have orders for all of this, so if you suspect a laceration or a hematoma, get the provider involved immediately. Retained placenta is also a cause for increased bleeding. Poor separation, more common in preterm babies, particularly 24 weeks gestation, might be a cause. In the non-adherent placenta, the provider manually goes up in mom's vagina into her uterus and manually pulls the placenta off the uterine wall, or pulls any placental fragments that are still there out of the uterus. There's a picture of this on page 713. In an adherent placenta, where there is no separation between the placenta and the uterine decidua, this cannot be removed manually without risk of laceration or perforation of the uterus. Examples are placenta accreta, which is a slight penetration of the myometrium, placenta increta, which is deep penetration of the myometrium, and placenta percreta, which is complete perforation of the uterus by the placenta. And a surgical removal of the placenta, and more than likely part of the uterus, or maybe even the whole uterus, might be needed. Mom might end up with a hysterectomy and probably lots of blood replacement. And speaking of placenta accreta, talking about uterine inversion, the only time I ever saw a uterine inversion in person was when an accreta had gone undiagnosed. The provider was pulling on the placenta that was abnormally adhered to the wall of the uterus and actually pulled the uterus inside out. Not a good day, but that's what happens with a uterine inversion and a placenta accreta. So contributing factors, of course, accreta, which is what I already said, fundal implantation of the placenta, vigorous fundal pressure, excessive cord traction or pulling on the cord, and uterine atony are also factors that can cause this. This occurs most often in multiparous women who have a placenta accreta. And prevention, don't pull on the cord or the placenta unless you're absolutely certain that it has separated. And treatment involves relaxing the uterus with some sort of uterotonic and actually pushing it back into place and possibly treating mom for shock. This is, like I said, this is not a good thing. Hypovolemic shock is what happens when we as care providers don't pick up on the fact that mom is bleeding too much. Once again, she might not show the classic signs until she's lost almost half of her blood volume. We don't want to wait that long. We need to be assessing her fundus, checking her lochia, listening to her if she complains of abnormal amount of exhaustion or severe pain in her perineum. We are always to be looking for these things. And if we do, then we won't have to worry about hypovolemic shock. Coagulopathies. These conditions can cause mom to bleed, but the first two, if she's had good prenatal care, we'll usually know about ahead of time. ITP is an autoimmune disorder where the lifespan of platelets is decreased. The woman has thrombocytopenia and capillary fragility and increased bleeding time. She has an increased risk of hemorrhage, and since it's an autoimmune disorder, it can be treated with corticosteroids and maybe even platelet replacement. Von Willebrand's is a type of hemophilia. It's very rare. It's basically where the factor 8 of the clotting factors is not there, along with platelet dysfunction. And moms can have an increased risk for bleeding for more so than normal for up to 4 weeks postpartum. And last is DIC, disseminated intravascular coagulation. And this is not a condition we can diagnose prenatally. During pregnancy, if there is an abruption or the mom's fetus dies or is retained in utero, mom has a severe preeclampsia or septicemia or sustains a hemorrhage, she may actually use up all of her clotting factor, in which case she's at risk for hemorrhage, and that's kind of what happens with DIC. Uterine subinvolution is when the uterus doesn't involute the way we expect, or slower than normal return to its pre-pregnant state. And the longer it's kind of big and floppy, the more risk there is for bleeding. Causes are retained placental fragments, pelvic infections. Subinvolution is also a cause for late postpartum hemorrhage. Symptoms are prolonged lochia flow, so her lochia rubra is supposed to last for, a certain number of days. If it lasts longer than that, then we're concerned. Or any irregular or excessive bleeding, of course hemorrhage. Or if the uterus is just larger than normal, we always assess where the fundal height, where is the fundus? Is it at the umbilicus or a little bit below? And depending on how many days out she is, it should be at a certain spot, and if it's not there, we need to be concerned. Or, of course, if the fundus is boggy. Treatment usually involves fixing the underlying problems, so if we need to get rid of an infection or manually remove pieces of placenta, then we need to do that. Whatever causing the problem needs to get fixed, or else the bleeding is going to continue. Postpartum infections is another main cause of problems after bleeding. Endometritis is the most common, and usually begins at the placental site. The incidence is higher, especially after a C-section, and some symptoms include fever of greater than 100.4, elevated pulse, chills, anorexia, nausea, fatigue, pelvic pain, uterine tenderness, foul smelling, and profuse lochia. The fever that I mentioned is after the first 24 hours. A fever before 24 hours does not necessarily mean an infection. That might just be the normal response to delivery. Wound infections are also, I'm not going to say common, but not uncommon. Sites include C-section incisions or episiotomies or lacerations, and symptoms, kind of what we discussed earlier, Rita, redness, erythema, all that stuff. Also warmth, tenderness, purulent drainage, wound separation, and possibly fever and pain. Treatment includes broad spectrum antibiotics in most cases, If the infection involves a wound, in which the wound is usually opened, evacuated, and debrided, and then allowed to heal by secondary intention, which means that the wound will not be sutured closed again. They'll be allowed to heal kind of from the inside out. This will take significantly longer and require meticulous wound care, but closing the wound again, if there's still even a little bit of infection there, is worse. Next, we have UTIs and mastitis. UTI, of course, the main risk factors in the postpartum period are catheterization. Every mom usually comes out of a C-section with a catheter in place, and most moms who get an epidural will get one placed while she's in labor. Also, overdistension of the bladder or trauma to the urethra or bladder during birth. Some symptoms are dysuria, frequency, urgency, maybe a low-grade fever, urinary retention, hematuria, and she might have flank pain if the kidneys are involved. Then now we have mastitis, which is almost always unilateral and develops after the milk flow is established, which is, as we said, after day 3 to 5. Symptoms are chills, fever, malaise, local breast tenderness, swelling, redness, axillary adenopathy. Treatment for both of these is antibiotics. For mastitis, tell the mom to keep nursing or pumping to kind of evacuate that area. Bed rest for 24 hours and increase fluid intake. Wear a supportive bra, and moist heat locally and analgesics are very helpful. There's a table on table 30-3 on page 726, has factors associated with developing mastitis, and there's a chart on page 728 comparing engorgement, plugged ducts, and mastitis, so you can see the difference. Thromboembolic disorders is next. We kind of talked about this already, but just to summarize, the risk of thrombus formation is increased in the postpartum period. The thrombus can be superficial, which is most common, in which there's pain and tenderness in the lower extremities, along with warmth, redness, and an enlarged hardened vein. Management includes analgesia, usually NSAIDs, rest with leg elevated, elastic stockings. Anticoagulants are usually not necessary, and pulmonary embolism, or PE, is very rare if it's superficial. Deep vein thrombosis, or DVT, is usually unilateral, lots of pain, calf tenderness, swelling, possible changes in limb color, and there might even be a fever. Management for this does include anticoagulant therapy, along with bed rest with the leg elevated, analgesia, stockings. And stockings, if the patient does have to get out of bed, usually we let them ambulate to the bathroom if they have to go. Other than that, they're probably on bed rest. If a mom does develop a pulmonary embolism, she will exhibit signs of dyspnea, tachypnea, apprehension, cough, tachycardia, elevated temp, chest pain. A PE is a life-threatening condition. Nursing interventions include elevating the head of the bed and oxygen with a face mask, narcotics to decrease pain and anxiety, but be careful because they can also decrease respiratory effort, and call the doctor immediately. Treatment will usually be IV heparin, strict bed rest, analgesics, and maybe eventually weaning her to Coumadin. If the patient is going to be on Coumadin, though, we need to make sure that she knows which foods are rich in vitamin K, as these need to be limited while she's taking this medication. There's a list of these foods listed on the teaching highlights on page 734. We talk a little bit about this too, but it bears repeating. Postpartum depression, as I said, is the most common ailment suffered by postpartum women. Postpartum hemorrhage is the one most likely to kill her, but postpartum depression is more common than postpartum hemorrhage. Primary prevention strategies for postpartum depression are on page 740. Postpartum or baby blues are mild and and are a transient condition, usually occurring in 50 to 80% of postpartum women. So most women are going to feel blue the first few days after delivery. Women on their 3rd to 8th day after birth is when it's most common. It may last for a few hours or several weeks. Postpartum depression is much more intense. It's a pervasive sadness, no periods of happiness. Mom may exhibit sleep disturbances, loss of energy, inability to function, eating problems. She feels inadequate as a mom. If she has any signs of depression, of normal depression, including suicidal ideation, this needs to be reported. This happens in about 8 to 20% of all postpartum women, and can happen any time in the first postpartum year, but is most common in between 3 weeks and 3 months. A mom who suffers from postpartum depression is also at risk for postpartum depression in subsequent pregnancies, and it can also lead to chronic depression. Postpartum psychosis has all the same traits as postpartum depression, but mom also has delusions and hallucinations and phobias, thoughts of killing herself and her infant. This is very rare. It occurs in only 1 to 2 out of 1,000 births. But I never want to let a mom leave the hospital without knowing that these are out there. Baby blues she might exhibit while she's there in the hospital. But by the time 3 weeks rolls around for postpartum depression, she's home, and she's been home for a while. So I'm not going to see this. So I always want to cover this during discharge teaching, and I always wait to cover these potential problems when the partner or the support person is there, because they'll usually be the first person to pick up on the fact that she's not acting like herself. If she's really gone, she might not even realize how differently she's behaving, and it might be someone else who points it out to her that, you really need to go get help. Here is a link to a YouTube video for the trailer of Dark Side of the Full Moon. This is a documentary that I was fortunate enough to see at the last A1 convention I attended. It's very powerful. I can't show the entire documentary, but I want to show you the YouTube video so you can see that postpartum depression, we don't hear a whole lot about it. We hear a lot about hemorrhage, about infection. We hear a lot about blood pressure, diabetes. We hear a lot about all these other things. Postpartum depression is very, very important and very, very significant and very, very debilitating to the moms who suffer from it and the children who are being raised by those moms. So if you guys have time, this material on this video is not testable. I want to tell you guys that. But it's only about 3 minutes, and I think it's worth watching. If a mom who's on any sort of psychotropic drug wants to breastfeed, they need to know that some of the medication does pass through the breast milk, although not usually in the amounts needed to cause any problems. So it's usually safe as long as she's on the lowest dose possible and just on one medication versus several, except for lithium. Lithium is not given to breastfeeding moms. Parents need to be educated if the mom is on lithium or on any psychotropic med, and so they can weigh the pros and cons and make an informed decision. Maybe they want to change the med, or maybe they want to stop breastfeeding, but they just need to know. And post-traumatic stress disorder, we talked about this in the pregnancy complication presentation, but it can still happen in the postpartum period as well. About 1% to 6% of women meet the diagnostic criteria for PTSD and may exhibit any of the signs listed here on this slide. Treatment, once again, like we talked about in the previous lecture, is counseling, therapy, and medication. So we have come to the end of another lecture. We have gone all the way from pregnancy, through delivery, through postpartum, and now our fictitious mom is delivered and home with her baby, and they're a happy, healthy couplet. So my work here is done, and I'll turn you back over to Dr. McDonald, who will talk to you about all the ins and outs of the pediatric population. So I thank you for your attention, and I will see you in class.